Good morning, everyone. I'm Kimberly Chawley with PHCA. Thanks so much for joining us for today's webinar, presented by Jennifer Dunlap and Linda Lewis. Welcome back, guys.
Thank you.
Yeah, a few quick updates to share before we get started. This webinar is being recorded and will be made available on the PHCA website within the next 2 weeks. The webinar has been approved for 1.5 continuing education credits for all attendees. For those who provided a NAB number, credits will be uploaded shortly. As we begin today, all attendees will be in listen-only mode. Please feel free to submit questions via the Q&A icon on your screen, and we'll make sure to answer as many questions as possible at the end of today's presentation. And I'll turn it over.
Good morning, everyone. We're actually going to go off camera so we can focus more on the webinar itself. There we go. So we're going to discuss the Pennsylvania DOH changes that are upcoming. Most of them are going to take effect in July of 2023. However, there are some other additional dates to be aware of. This kind of came out before the CMS changes. So that is one thing that why we're looking at those now. Just our disclaimer and our objectives. The reason they made these changes is because there is an increase in seniors in Pennsylvania, and of course, subsequently an increase in those needing long-term care services. Their last true update was in 1997. So they wanted to make substantial changes in the means of delivering care and providing a safe environment. It is irrelevant if you participate in Medicare and or Medicaid services. There are 3 facilities in Pennsylvania that are private pay only. That will be irrelevant. All facilities are going to be required to follow the requirements of participation. Throughout the presentation, you will see underlined words, phrases, etc. That means that is what is new. Their intent was to improve quality of care and create consistency between federal and state requirements. They're going to update the existing definitions, clarification of staffing, make the survey process more efficient, and eliminate confusion in the application of standards. A lot of things are going to follow to the federal guidelines. So you want to look back at State Operations Manual Appendix PP. Even though it says State Operations Manual, it is the federal or CMS guidelines. Be aware that there were changes to Appendix PP effective June 29th of 2022 in a memo QSO 2219NH. And that's relative to surveyor guidance for facility reported incidents and psychosocial outcomes. They did that to strengthen the implementation of phases 2 and 3 from 2016 and offer changes relative to stakeholder feedback. The requirements of participation, there were changes effective as of October 24th. Continue to monitor the State Operations Appendix PP for updates and critical element pathways. And just for anyone who is unaware, the requirements of participation and FTAGs are the same thing. As I said, unless specified, the changes take effect on July 1st of 2023. It's really important to note these effective changes and look at these now because there are policies and procedures that are going to need to be put into effect. The applicability, they are changing the phrases, or deleting the phrases profit and nonprofit because it's going to apply to all long-term care facilities, regardless if you're profit or nonprofit. Requirements are going to incorporate 42 CFR Part 483. Again, this is from the State Operations Manual. They're making it more generalized. Currently it says 483.1 through 483.75, so they're going to delete that and just make it 483. There were comments made in the comment phase of the rulemaking for the 3 private pay facilities needing to have a grievance policy. People were commenting that it would take extra financial needs to have the grievance policy into effect. Pennsylvania came back and stated that although the facilities are all going to need a grievance policy and procedure, there has to be a grievance officer to oversee the process, receive and track grievances, lead any necessary investigations, and maintain confidentiality of the residents. It is a new requirement for private pay facilities. However, the grievance officer does not need to be a full-time person, does not need to be new personnel, so it should not be a financial detriment to those private pay facilities. There are a lot of definition changes. Again, their last rule update was in 1997. So some of these definitions have been updated throughout the years. We're not going to go over all of the definition changes. They're included here for your reference. Remember that these vocabulary changes will be consistent throughout the regulations. So if they're giving you a regulation change or a definition change here, it will remain throughout. Abuse, they're going to change the overall general abuse definition and be separated for specificity. And some of the definitions were being deleted because the ordinary dictionary definition is applied. And these are all here for your reference. Some of these are going to utilize a cross-reference, so such as administrator. They're saying that it's already defined in the state operations manual, as you see there. There is a slide towards the end which does include some of the cross-references. So you'll see clinical laboratory is in the USCA. I have included that later in the presentation. They're also utilizing acronyms for RN and LPN now. Previously, they wrote it out every time. Replacements, they are replacing the word drugs with medications and the word patient with resident. And then there are some additional definitions that are going to be put into the regulations. The big one is charge nurse. They're just adding that it can be an RN. Previously, they were going to have it where they were going to waive that you could be a graduate nurse. They are not going to include that, but it is going to maintain that it can be an LPN in the facility as a charge nurse on the night shift with a census of 59 or less.
And you see the reference there to section 211.12. They do clarify in that section that the charge nurse, there has to be one appointed on each tour of duty.
And a lot of these, they're just making these changes to be more consistent. In 201.12, most, if not all of our attendees probably will not need this information, so it is here for your reference. However, they are changing these regulations to ensure licensees do not have a history of poor care, financial problems, or etc. throughout the entire United States. They're really trying to buckle down on somebody that could have been, in another state, had some poor outcomes, and then come into Pennsylvania and get a license here as if nothing happened elsewhere. So they are looking out for the safety of our residents. We're just going to kind of skim over this. As I said, most of you, I do not believe will need this information, but when you are able to download the presentation, it is here for your reference. The application, just so you're aware, they are adding, if you have any other facilities throughout the United States, and they're adding email addresses. So it'll be name, address, phone number, and email address. They're just trying to come into the 21st century.
Well, and I think increased transparency. They want to know who the operators are, and they want the consumer to be able to access that information as well.
There are some dates here, as you can see. 201.12a, the notice and opportunity to comment, that is going to go into effect February 1st of 2023. They just wanted to get ahead of the need for certain information, so they figured 5 months they should be able to have all of the required information in effect by July 1st. And again, as Linda said, it's increasing our transparency. So this information, when you apply for a license, it's going to be put out on the public DOH website. And that is going to give people opportunity to evaluate. If they know of any incidents in other states, they are able to comment. And if you're applying for a second license in PA or subsequent, people are able to comment if they've had issues with previous ownerships. The evaluation will begin on October 31st of 2023. A regular license, it is the same as previous. It will be a 1-year license as long as you are in full compliance with Section 808 of the Act, or full or substantial compliance with the provisions in 201.13. A provisional license, we know that is only for 6 months, and you have to take appropriate steps with your plan of correction, and there is no cyclical pattern of deficiencies over 2 or more years. Upon determination of substantial compliance and you paid any fines and fees, then a regular license will be issued. All of this goes into effect in July of 2023, except for B and C here. That'll go into effect October 31st. So you have to have the form and fee, the annual financial report that meets requirements. So when you apply for a license renewal, starting on October 31st of 2023, you're going to have to include an annual financial report. That is just increasing the transparency. So 21 days before the expiration, you have to include the financial report unless the Department of Health requires that before the 21 days. There is a little more explanation as far as the financial report included within. However, most of it is just a standard financial report, but it will be on your renewal form. Okay, 201.14 is the responsibility of the licensee. This is your reporting. It used to just say as soon as possible, but now it's going to say as soon as possible or at the latest within 24 hours for any event reporting. This is going to take more of an account of who is going to do the reporting for event reports. So make sure that you have a process in play. If it occurs on a Friday evening, if it occurs on a Saturday or Sunday and administration's not there, I know a lot of facilities had, we'll do it on the next business day, or they would have somebody initiate the event report and then it would be finished later. Well, this information needs to be put within 24 hours at the latest. And that includes notification to the Office of State Long-Term Care Ombudsman in the event of a strike. Previously, it was just the Department of Health, but now they want the ombudsmans to be aware as well. Again, and when you see the underlined, that is something new. So the licensee previously had to report the census rate and the program occupancy, but now there is any other additional information Department of Health may request. This is in lieu of COVID, because in such instances as during the pandemic, information that was required to be reported was rapidly changing, such as certain numbers of vaccinations, positive cases, etc. So it is imperative to follow rules, regulations, and orders being issued from the multiple federal, state, and local state statutes. Again, the facility-wide assessment, they want the assessment done quarterly. Federal guidelines initially was annually, but now it will be quarterly. Any restrictions on a license, it's going to be automatically void if it expires. Prior to that, it wasn't an automatic void when it became expired, because sometimes there are delays. But now it will expire unless there is a departmental delay, a federal emergency, or state disaster emergency. The enforcement really has not changed. You have to have a plan of correction if you have deficiencies. There could be the issuance of a provisional license, as we know, license revocation. They could appoint a temporary manager. There could be limitations or suspensions of admissions into the facility, and assessment of fines or civil money penalties. In the appeals process, a final determination can be appealed to the Health Policy Board under 2102N of the Administrative Code. License location, they're going to continue to consider the facility as a distinct unit and prohibit the facility from mixing approved beds. So if you have a CCRC, of course, you cannot have some of your long-term care beds in your personal care or vice versa. Cannot mix residents and staff between the health-related services. So you cannot have somebody from your personal care working in your skilled unit, again, and vice versa. But you can share centralized services such as laundry and meal preparations to reduce costs. I just wanted to alert people to this, more so because I have seen where if you have problems, if you have a PC and a skilled unit in the same building, sometimes they would utilize a nurse from the skilled unit to assist in personal care, especially on off shifts. That cannot happen. There is an addition to management into a 1.18 that the governing body of a facility needs to have rules to enforce the return of any personal property remaining at the facility within 30 days after death or discharge.
And I think most buildings probably already have such a policy in place, but in the event that you don't, just review policies and procedures and make sure you get that into your written policy manual.
And the governing body shall report to the Department of Health within 30 days any changes that was submitted within the facility's application. So if there were, you applied for a license and there were changes, say there was an error regarding a typo of location of the facility, you have 30 days to make changes. That way, when you submit an application and there was an error, it isn't automatically denied. They are giving you 30 days to make changes appropriately. Make sure that your administrative and resident care policies and bylaws are updated as often as necessary, but at least annually. And that needs to include requests to resident representatives, and review by members of the public. We know that our policies and procedures need to be updated annually. You need to make sure that you are also documenting that they were reviewed and or revised. When you have an administrator, they are able to share an administrator between two facilities as long as both facility is 25 beds or less. And you need to inform the DOH of the arrangement. There is a plan in the event of an emergency when the administrator is not there. The residents and resident representatives need to be able to contact the administrator. How are they going to do that?
Make sure that you include that in your emergency plan that's required, of course, under Appendix Z.
Your Director of Nursing Services has, at a minimum, the knowledge and experience of the facility. So don't have a brand new DON in the building and the administrator not be there. And then the sharing of the administrator is limited to 2 facilities. The administrator's bi-weekly work schedule needs to be publicly posted within the facility. And if that work schedule changes, it needs to be updated within 24 hours of that change. Increasing the transparency to your resident population. And ensure that a sanitary, orderly, and comfortable environment is kept even though the administrator is not in the building. And then include that everything occurs as necessary, but at least on a monthly basis.
Okay, I want to add a little bit to that. That is relevant to the administrator's ongoing relationship with the governing body, the medical and nursing staff. And they are they're requiring that that function take place on a monthly basis. So you're going to need to have some way of demonstrating that the administrator is on a monthly basis reporting to the governing body and having some kind of contact meetings with medical staff, nursing staff, and so on.
And if the resident requests finances, from their funds, if they request cash, it has to be within 1 day of the request, a check within 3 days. And if you utilize electronic funds, the electronic transfer needs to be initiated within 1 day of the request.
So this is probably something that not all of the buildings are doing at this point in time, given the difficulties with having cash available over weekends. So you will need to develop your policies and procedures. You'll need to decide who can have access to the cash, who is the resident supposed to approach to implement this process, and what are the ins and outs of making it happen.
For personnel records, they're just adding the word facility before employee to clarify that this section applies to employees of the facility, not agency employees. They've really put into account what requirements are going to need to be kept in these personnel records. So this is important for your HR director to be aware of. Your job description, educational background, employee performance evaluations, and just note the federal guidelines only highlight performance evaluations for nursing assistants or nursing aides. This requirement is going to be for all employees. And then credentials, certifications, licensures, and then determination that the employee is free from any communicable diseases or conditions. The medical exam or attestation that the employee is able to perform duties, orientation process, documentation of the required trainings that we will discuss later, and then your Pennsylvania State Police or FBI report as ordered by OPSA.
So you want to make sure that you have a process in place so that the employee's orientation to the facility takes place promptly. And one of the things that had been traditional in our industry, but I suspect many of you are doing it differently now, you know, we used to start new employees every 2 weeks. These days with the staffing shortages, it's really imperative that you be prepared to get someone oriented very promptly after they accept a position, because we all know they can go down the street and get a position elsewhere, you know, just about any time. So put your orientation processes in place, perhaps with some self-learning modules or other processes, so that orientation can be accomplished on an as-needed basis, not just on an every 2 week or a monthly calendar.
And regarding background checks, in the event of a conviction prior to or following employment, you need documentation that the facility has really determined the suitability for initial or continued employment. The suitability for employment is going to be defined as including a review of the offense, the length of time since the individual's conviction, the length of time since incarceration, if any, evidence of rehabilitation, work history, and the employee's job duties, plus the employee's completed employment application.
So we recommend that in advance of these regulations becoming effective, you develop a policy that spells out in considerable detail which offenses will result in the facility excluding someone from direct resident care versus which offenses are going to result in you allowing access to the residential living environment, but perhaps not do direct care, versus still yet removal from employment or obviously rejecting them for hire. And I do recommend that you seek some guidance on that policy from your labor counsel.
What they're really trying to do is, if you made a mistake early in your life and got in trouble with the law, they don't want to make it so, you know, for the rest of your existence, you're not able to work in healthcare. So it can be a good thing, but you really want to look and see ahead of time, what are you going to include, and, you know, what are you automatically not going to let somebody work in your facility. Staff development. So we know that we have to have annual in-service training on certain topics. 42 CFR 483.95 does, it already has existing topics that are outlined, but Pennsylvania is also going to require accident prevention, restorative nursing techniques, emergency preparedness, fire prevention and safety, resident rights. That is going to include non-discrimination and cultural competency. Please make sure that you're looking at this stuff moving forward, because we know that, you know, cultural competency, non-discrimination, that is rapidly changing in our culture. Any training needs identified in a facility assessment. Making sure that employees receive the appropriate training on orientation, on prevention, detection, and reporting of resident abuse, dementia management, and communication skills. So we've always really done resident abuse training, but now they really focus on dementia management and communication. Make sure that we have written records maintained as to your staff development programs. We wanted to include what is required under the federal regulations. So you see here what is required. The STAR is included because it necessitates ongoing revisions due to changes in your facility resident population, physical environment, staff turnover, and modifications of the facility assessment. please make sure that you're looking, if you on orientation are constantly doing a certain in-service training, because you have constant staff turnover, is there anything else that you need to include? Some of the federal suggestions based on the outcome of a facility assessment can include advanced care planning, cultural competence, end-of-life care, geriatrics and gerontology, substance abuse, working with young and middle-aged adults. We know that some of our population are becoming younger and younger. Grief and loss, interdisciplinary collaboration, person-centered care, trauma-informed care, intellectual disabilities, mental disorder, quality of life, and care.
So you see the list of staff development requirements continues to grow. It just keeps getting longer and longer. And if you're not a facility blessed with a dedicated educator, I recommend at the beginning of a calendar year, a fiscal year, a federal year, however you want to define a year, but I recommend that you plan your in-service education for an entire year at a time, doing at least an assignment of who will be responsible in your building to either find and bring in a speaker or develop and deliver the in-service education. That way there's no last minute surprises and everybody knows what the expectation is, and you have the comfort of knowing that you've covered everything on the required list. And then of course you need to add to the requirements anything that you've identified through either your facility assessment or in those employee evaluations that you do. If you're identifying a trend through the evaluations, then that needs to be added to your staff development.
And I know a lot of facilities rely on a third party to do a lot of their education practices, but you cannot just rely assume the fact that they are going to cover everything that needs to be covered. You really need to take a look at that because it is not facility centered. These are generic educations that they put out for the staff. So really look at that and see if maybe you need to critique that, or as Linda said, bring somebody else in to do an in-service. We also wanted to include the FTAG 947 for nurses' aides. We know that our nurse aides need to have no less than 12 hours per year, but that needs to include dementia training, resident abuse prevention, and any areas of weakness determined in performance reviews and facility assessments, plus the care of the cognitively impaired. 201.21 looks at the use of outside resources. So that's our outside vendors plus our agencies. You need to have the responsibilities, functions, objectives, and terms of agreements related to outside resources. It needs to be delineated in writing and signed and dated by both parties. For your agency, you need to obtain confirmation from the outside resource that the employees are free from communicable disease and conditions and are able to perform their assigned duties. All it has to say is the facility receive this communication or confirmation. You do not need to have their medical documentation, just the fact that the agency has that available if there is a question. 201.22 is regarding tuberculosis. They're going to utilize the CDC guidelines related to TB screening, testing, and surveillance. So we did include, the form, the link there for the 2021 TB screening and testing. A lot of places in PA facilities were utilizing annual TB screening for their staff, and that is not a requirement now. It is upon hire, and if you go to any high TB areas. So if you go overseas where tuberculosis is an endemic there, or if somebody comes in contact with somebody with an active TB case, then you would test them. Closure of a facility, we hope that you don't need this information. However, it is updated and will be in the presentation for your reference. Just so that you're aware, it used to be a 30 to 60 day notice to the Department of Health. Now they're just saying, please notify us as soon as possible. So the information is here for you. They are going to request certain information, so the payment of salaries and expenses, continuation of appropriate staffing and resources through your closure date, ongoing accounting, maintenance, and reporting of resident personal funds even after you close, labeling, safekeeping, and appropriate transfer of personal belongings. The facility needs to have approval of closure at least 75 days prior to the proposed closure date, and at least 60 days before the proposed closure date, you need to have it in writing to the residents and their representatives, employees of the facility, the long-term care ombudsman program, and the Pennsylvania Department of Human Services. That written notice needs to have the date of the proposed closure, any contact information for the facility representative, and contact information for the Office of State Long-Term Care Ombudsman Program. And no resident in the facility may be required to leave the facility prior to 30 days following receipt of that notice. Unfortunately, in our industry, a lot of facilities are closing nowadays. So just make sure that you have this information and follow everything that they have in effect. You see here under G that the facility shall provide proof of financial responsibility with the DOH, that the facility continues to operate in a satisfactory manner. It used to say for a period of 30 days following the notice of intent to close. Now it is until the closure of the facility. Admission policy, a lot of deletions here. It used to say that the resident may be permitted to name a responsible person. Well, they're just adding now that you are allowed to have a resident representative. The pre-existing C and D in this section is remained without any change. Really want to highlight here, in your admission policy, it needs to now include the governing body of a facility shall establish written policies for the admissions process and through the administrator be responsible for the development of and adherence to procedures implemented in the policies. Your policy and procedure needs to include the introduction of residents to at least one member of the professional nursing staff for the unit where the resident will be living, and to direct care staff who have been assigned to care for the resident. Prior to introductions, the professional nursing and direct care staff need to review the orders from the physician or other healthcare practitioner. What they're saying is some residents have been known to be brought into a facility. You know, if they're brought in by an ambulance service, they're put into their bed, and it could be hours before anyone ever comes to see that resident. They want that to be changed. You need to have orientation of the resident to the facility and location of essential services and key personnel, including the dining room, any nurses' workstations, which has changed from nursing stations, offices for the facility social worker and grievance or complaint officer, a description of facility routines, including what shifts they work, meal times, where the menus are posted, discussion and documentation of the residents' customary routines, such as in their care plan under 483.21, assistance in helping the resident create a home-like environment and settling and securing personal possessions in the room. The coordination of introductions, orientation, and discussions need to occur within 2 hours of the resident's admission. The activities within E3 and 4 need to occur within 24 hours, and then E5 needs to occur within 72 hours. So they are very specific on what they are requesting of the staff during an admission.
So you need to develop a comprehensive admission policy that puts a procedure into place and assigns responsibility for who's responsible for each step of the regulated admission process now. And then of course there may be training of staff that's required, and certainly you want to put this in your QA/PI monitoring for compliance, particularly since it's going to be, for some buildings at least, a new process.
The discharge policy is going to be deleted as it is included in the federal requirements. So they are changing from a power of attorney to resident representative. It cannot be a licensee, owner, operator, or member of the governing body. However, it can be a family member who is employed in the facility as long as there is no conflict of interest. And anyone who has been through this knows previously, it could not be an employee of the facility. Just make sure that if it is an employee of the facility, you have somewhere it's documented there is no conflict of interest. The facility can be a designated representative payee according to Title II or Title 16 of the Social Security Act and applicable regulations. Resident rights, it's just changing that it's through the administrator. The governing body is going to be who's responsible for the development of and adherence to procedures implemented in the policies. These policies need to include a mechanism for inclusion of resident representatives in the development, implementation, and review of the policies and procedures. So you need to have a develop a policy that places limits on this. For example, now that you're going to have residents and resident representatives involved in the development of this policy, can a resident vote to allow the use within the facility and grounds of illegal street drugs? So make sure that you have something in place that says, you know what, this cannot be a part of our resident rights. Again, anything underlined is something that is added. So we've always, according to regulation, federal regulations, we need to have our resident rights posted in a conspicuous place near the entrances on each floor. PA is just including that. A certificate of provision of personal notice needs to be included in the resident's medical record. Most of the time we include this in our admission paperwork, but make sure that every time that there is a change in the resident rights, that's also given to the residents and included in their file. In addition to 483.10, the residents have the right to the following. If there's changes in charges during the resident stay, you need to advise the resident or their resident representative verbally and in writing reasonably advanced of the change. Reasonably in advance is interpreted as 30 days prior to the change unless circumstances dictate otherwise. And if a facility is going to require a security deposit, the written procedure or contract given to the resident shall indicate how the deposit will be used. Prior to a transfer, the facility needs to inform the resident as to whether the facility where the resident is being transferred to and if they participate in Medicare and medical assistance programs. And then anything with experimental research, you will see there, it needs to include the DOH's IRB or their institutional review board. Okay, regarding 201.30 access requirements, that has been deleted. and 201.31 for transfer agreements has been deleted. Again, a lot of these were deleted because they already exist in the federal requirements. 203, the whole chapter is currently our life safety code. They're deleting this entire section because everything is incorporated in the federal regulations, or it's Appendix Z. We just wanted to note that Appendix Z was updated March 26th of 2021 due to the COVID pandemic, and there is a link there to the document that was sent out. Chapter 204 is going to be a whole new chapter. It's the physical environment and equipment standards for construction, alteration, or renovation of long-term care nursing facilities. This is for any approvals after July 1st of 2023. So you'll see that a lot of the pre-existing Chapter 205 regulations are going to be included in 204 just because 204 is for anything after July 1st, and 205 is going to be any approvals before July 31st or July 1st of 2023. So anything on or after July 1st is going to adopt the Federal Facility Guideline Institute's guidelines for design and construction of residential health care and support facilities. Anything before that is the Chapter 205 that's already existing. Note that you need to meet the requirements in effect on the date of your approval. Oh, and I also wanted to note, that this FGI guidelines is updated and published approximately every 4 years. 204.2 is coming from previously 205.4. A is added, so you need to submit the plans to the DOH, and then the DOH will post all of their instructions for submissions on its public website. 205.4A is now B, B is now C, and C is now D. The previous D has been deleted. E, the facility will obtain approval from the DOH before using an area of the facility for resident care when the area has not been occupied or used by residents for 1 year or more. Please make sure that you look if you've closed any wings or specific units in your building. That is going to be included. You cannot use that area if it's been closed for a year or more without DOH approval. They're just adding the word grounds here in 204.3. And they're adding if it's geographically and environmentally conducive to the health and safety of residents. The basement in 204.4, it's all coming from 205.7 and 205.10E. Resident rooms, A and C, is going to come from the existing 205.20. They're adding that the basement of a facility you cannot use for resident rooms. D, a resident shall have the choice of placement of the bed in the room unless that choice presents a safety hazard. You know, we're trying to make this a more home-like environment and allow residents some autonomy and decision-making. But if it's going to pose a safety hazard, then we cannot accommodate them.
So again, you want to get a policy on bed placements, and where a resident seeks approval to do a bed placement change, who implements that change, and so on.
And a resident needs to have a drawer or cabinet in the room that can be locked. 204.6 locks is already coming from 205.14, and then 204.7 laundry is coming from the pre-existing 205.26E. 204.8 utility room is being simplified the pre-existing 205.33A, but now they're going to say that a facility shall make provisions in each nursing unit for utility rooms. The nursing unit shall have separate soiled and clean workrooms, and the rooms may not be more than 120 feet from the most remote room served. Previously, they would say it had to be so far from a nurse's station and stuff like that. So it's more simplified in this version. Bathing facilities, it's going to come from 205.36, and you see how the changes are there. The facility shall have at least one bathtub in each centralized bath area on each floor. They are not using pre-existing 205.36 B, D, F, or G. 204.10 is the toileting facilities. They have to have an area that can be provided to visitors. Bathroom equipment, previously it would say that we had to have grab bars and of the such for 250 pounds or more. They're changing that those grab bars, accessories, and anchorage shall have sufficient strength to accommodate resident needs. This all falls back onto our facility assessment. Are we taking bariatric patients? And if so, do our accessories and anchorage have the sufficient strength to accommodate those needs for the bariatric residents? And the toilet room equipment, same thing. These handrails and assist bars, they need to be able to have the capability of accommodating the resident needs for our resident population. And 204.13 linen is from a pre-existing 205.74. 204.14 supplies is from 205.75. 204.15 windows is from the pre-existing 205.19, and 204.16 dining is from the pre-existing 205.24A. They are just deleting the sentence that says these areas shall be well lighted and well ventilated, because those requirements are under the federal guidelines. And you see here the cross references. 204.19, plumbing, heating, ventilation, air conditioning, and electrical. This is a catch-all section, replacing the requirements for new construction in 205.61 and 205 through 205.68. This is just states the building systems need to comply with all state and local codes. 204.20, I think this is probably one of the most important things that you need to be aware of moving forward after July 1st. You need to have an airborne infection isolation room. So again, this is something new because of COVID, but you have to have at least one airborne infection isolation room for isolating residents to prevent the spread of airborne infections. Previously, long-term care facilities just did not take anybody with an airborne infection. You can't do that moving forward because with COVID, our pre-existing residents were getting these airborne infections, and we can't just transfer them all out of there. So this means you're going to have an anteroom with negative pressure. So these are things that you really need to look at the Facility Guideline Institute to make sure that you are in compliance with that. Chapter 205, that is the existing physical environment standards. So this is going to be before July 1st. If you already have renovations that have been approved through July 1st of 2023, then these are the regulations you'll need to follow. In 205.21, there is a special care room section. It's just that provisions shall be made for isolating a resident as necessary in a single room which is ventilated to the outside. For new construction, there shall be an adjoining private bathroom which contains a toilet, lavatory, and either a standard size tub or shower. So these are for your people that need to be in a ventilated isolation room. they need to have their own area for hygiene purposes as well. The existing 205.22 placement of beds, they're just going to change that the resident can choose to change their beds as long as it does not pose a safety hazard. And you just see here that a lot of these, they're removing the word new just because it's going to be existing approved changes. Chapter 209, the fire protection and safety programs for long-term care. This section is also going to be deleted because they're utilizing the life safety codes in Appendix Z. 211.1, reportable diseases. In addition to the reportable diseases we're already reporting to the Department of Health, they're just going to add a bed bug infestation. Apparently there has been an uptick in the number of bed bug infestations in Pennsylvania. So they want that to also be reported.
And again, like everything else, update your policy to include that.
211.11, the resident care plan is being deleted because we're utilizing federal guidelines.
Okay, so now we're going to take a look at the requirements under nursing services at section 211.12. And this is where we've all been nervous about the increase in staffing requirements. But I think really as we go through this, you'll see that a lot of what is going to be required, many facilities are already in compliance with. And so it's not quite as daunting as what the proposed regulations led us to think. So of course they've retained the requirement for a full-time registered nurse as the director of nursing services. We've talked about the requirement for a designated charge nurse, and that has to be on each tour of duty. They have retained the current table of nursing staff ratios of licensed nurses based on census. So you may recall during the proposal process that they had updated that table and made quite a few changes. In the final form, the table that we've been accustomed to has been retained. So that certainly is helpful. So the new requirements effective July 1st of 2023, we're going to have a requirement of 1 nurse aide for every 12 residents during the day and the evening shifts, and 1 nurse aide for every 12 residents on the overnight shift.
And I just wanted to suggest, you see up in the corner a staffing matrix sample. I think that's pretty important for facilities to have because, you know, especially on off shifts, if you get these call-offs, you really need to determine for that person who's taking these call-offs, what do I need to do and how do I need to replace the call-offs? So kind of look at this and it'll help your staff out tremendously.
So in terms of licensed requirements effective July 1st of next year, you'll be required to have 1 LPN for every 25 residents during the day shift, 1 LPN for every 30 residents during the evening shift, and 1 LPN for every 40 residents on the overnight shift. Notice, of course, that they're using the traditional 7 to 3, 3 to 11 to 11 to 7 or similar, rather than 12-hour shifts. So in your scheduling, you just have to be aware of that and make the adjustments accordingly. Effective 7/1/23, then you need a minimum of 1 RN for every 250 residents during all shifts. And if you have a census equal to or less than 59, you may substitute an LPN where an RN is required on the overnight shift, but only if an RN is on call and within 30-minute drive of the facility. Then the next increase in staffing requirements comes a year later on July 1st of 2024, when you'll need to have 1 nurse aide for every 10 residents during the day, one nurse aide for every 11 residents during the evening shift, and one nurse aide for every 15 residents during the overnight shift. And then in terms of licensed staff, July 1 of 2024, there is no increase in the LPN requirements and no increase in the RN requirements over what was implemented 7/1 of 23. And at any given point in time, there must be at least one nursing staff employee on duty for every 20 residents and at least 2 nursing personnel on duty at all times, regardless of how many residents in the building. Then in terms of a per patient day requirement, so we've got to comply with both. We've got to comply with the ratio requirements, and we'll need to comply with the hours of care per patient per day requirement. So effective 7/1 of 23, when totaled for the entire facility, you must run a minimum of 2.87 hours per patient day of direct resident care. And I think really the great majority of buildings are already doing this. As of 7/1 of 24, when totaled for the entire facility, you must have a minimum of 3.2 hours of care per patient per day of direct resident care. And again, I think the great majority of buildings are already meeting this requirement. Note that you can count only direct resident care provided by nursing service personnel.
And that's a change from the federal requirements. Federal requirements are any discipline that is providing direct care. So that was including therapy services on day shift. On Pennsylvania, your PPD is only nursing service personnel. So then we look at dental services. We need to make sure a facility has provisions to assure that resident dentures are retained by the resident. How many times do residents lose dentures? It happens so often, but we need to make sure that we do the best we can to try and make sure that those don't get lost and that all the dentures are marked for each resident. So include this in your policy. Include this in your admission checklist to make sure that these things are being marked on admission. Social services, you have to employ a full-time social worker unless you have a facility with 26 to 59 beds. You can have a part-time qualified social worker if the facility assessment indicates a full-time is not needed. Or if a facility has less than 25 beds, you can have a part-time qualified social worker or share services with another facility. Pet therapy, a facility shall have a written policy and procedure to ensure animals are up to date on vaccinations. They're changing from the word pets to put animals because, you know, sometimes you have other people that, you know, bring animals in for an activity or whatever, and they're not necessarily a pet. So it's all animals are up to date with vaccinations, in good health, not proposing a health and safety risk to the residents. Any place the animals are reside or visit are kept clean and sanitary, and make sure that you follow infection prevention and control measures such as hand hygiene by residents following handling of the animals. The medical director, and I really truly think that this is also another area that is changing that is going to be of importance for all of us to look at. It used to be physician services, now it's medical director. Now your medical director, we all know they needed to be licensed in the Commonwealth, but now they have to complete at least 4 hours of CME pertinent to the field of medical direction or post-acute and long-term care medicine. So you're gonna have to get on your medical directors about this. And I would also have something in place where they give you a certificate to include in their file to make sure that if you are asked about it, you have that documentation.
So obviously you need to educate your medical director to the new requirement, but you may also need to introduce them to what used to be called AMDA. It's not called that anymore, but it's the organization that supports medical directors in long-term care. And then you may want to update your contract with that physician to include this as a requirement. And if you don't want to redo the entire contract, you may want to do an addendum, but it's probably a good idea to get in writing that it is a requirement for the CME to be done.
The medical director responsibility needs to include appropriateness and quality of medical care, assisting development of educational programs for the staff and other professionals, and working with the facility's clinical team for surveillance, potential infection of residents, looking at your infection control requirements, cooperating with facility staff to establish policies for resident rights, supporting and promoting person-directed care, identifying performance expectations and facilitating feedback to other physicians and practitioners, discussing and intervening with healthcare practitioners inconsistent with current standards of care, assisting in developing systems to monitor the performance of those healthcare practitioners. So what they're saying is medical directors have responsibilities, and we need to hold our medical directors to these responsibilities. You know, they don't just come in and do their own residents and leave for the day. You need to make sure that they're looking at everyone's care and making sure that you're all following, you know, all physicians and practitioners are following appropriate scopes of practice and standards of care. Verbal and telephone orders, they're changing from oral orders to verbal orders, which we all know. They're also adding that if these orders can come from the physician or a physician's delegee, just because we know that PAs and NPs are also allowed to give these orders. Verbal and telephone orders for meds need to be dated and countersigned by the prescribing physician or designee within 48 hours. They're trying to decrease the number of errors. So they think if it needs countersigned within that 48 hours, the likelihood of an error decreases, or the likelihood that an error continues for an extended period of time will decrease.
So it's a good time to be reinforcing these requirements with your physician providers. And it's also an excellent QA/PI project to be monitoring whether or not these signatures are occurring as they should. And remember, it's not just a signature. When that physician signs, he's supposed to be authenticating the order, which means that he or she has reviewed the order and by his or her signature affirms that it's been accurately transcribed by the nurse who received it.
Yes, and they are able to countersign whether it's sent by a fax or if they go into the electronic health record and sign it in that way. As long as it is done in either which way, or signed at the facility, which is also fine, but as long as it's within those time frames.
You see the reference there to secure electronic transmission. It might not be a bad idea to do a QA/PI project to make sure that your nurses haven't found workarounds. I have known nurses to have cell phone numbers for the physician community and text them, and the physician texts back orders for residents. So do a monitoring activity to make sure that those kinds of workarounds have not been implemented by nursing staff.
And then in the procedure for an event of death, it's not just the procedures need to be available to nursing, it needs to be available to all personnel. They're also changing back from clinical record to medical record. This also puts into effect what information needs to be contained in the resident's record. This is good for your medical records personnel to have all of this information, and moving forward, make sure that all of this is involved. It'll include written consent for authorized representatives of the state and federal government during the conduct of their official duties. Written consent is not necessary for release of medical records for treatment purposes in accordance with federal and state laws. It's replacing notify the Department of Health of how many records may be obtained with providing the Department of Health within 30 days of providing notice of closure, a plan for the storage and retrieval of medical records. The medical record needs to include, and you see everything there, which I believe most of this we already include, but they're just making it where it is in writing that it needs to be included. Okay. And 211.6 for dietary, we know that menus need to be planned at least 2 weeks in advance. They're adding the fact that it needs to be posted in the facility or distributed to residents at least 2 weeks in advance. So make sure your dietary services is aware of this change.
And like everything else, make sure it's included in your policies and procedures. And of course, be attentive to wheelchair height if it happens that you're posting it rather than distributing it.
Physician assistants and certified nurse practitioners, they're deleting a lot of these just because it will be in the federal guidelines as well. And they're changing nurses' stations to workstations. You'll see that throughout the regulations. Restraints, most facilities don't use restraints, but in the event that they do, you need to have the least restrictive method for the least amount of time. It needs to be in the comprehensive assessment and in the comprehensive care plan. You need to have documentation of the need for the restraint, the personnel responsible performing the intervention on each shift, the type of restraint, each time the restraint is used or removed, and note that it needs to be removed at least 10 minutes every 2 hours during normal waking hours to allow the resident to move and exercise. And during normal waking hours, the resident's position needs to be changed at least every 2 hours. Your appropriate interventions can include turning and repositioning, providing distractions, checking the skin, supervising the resident. In the event that you decide to use restraints in your facility, you need to educate your staff on this, because this is something that they will buckle down on, and it could be considered abuse if you do not follow the regulations here for using restraints. Pharmacy, you need to have a written policy and procedure for the disposition of meds that address timely and safe identification of storage methods, and control and accountability of meds awaiting final disposition. Work with your consulting pharmacist and see if they can help you put this stuff into effect. A lot of these pharmacies probably already have something. Documentation of the actual disposition of the meds, who disposed of them, what the prescription number was. They're trying to prevent diversion and accidental exposure. There have been a lot of diversion activities, and they're trying to prevent some of this. The other change there is regarding the emergency kit. It needs to be readily available to staff. Your policy and procedure needs to have the content, storage, security, refill, and inventory tracking for the kits. Previously, it said that you had to have one of those breakaway locks, and they recognize that a lot of facilities now have electronic Pyxis machines, or whatever you call them. So they're getting rid of that for the breakaway locks, but it has to be secured one way or another. Plus, how are you doing your inventory tracking? The contents of the emergency kit needs to be relative to what your needs are in the building. So it cannot be just cookie cutter e-kits for every facility. They need to really review the kits annually, review the needs annually. So make sure that you have something from your pharmacy that states that they are reviewing your e-kits and the contents. This is some of the cross-reference websites that I discussed earlier. There is a lot of crosswalks throughout these new PA regs, whether it is they're referencing the federal guidelines, whether they're referencing the former PA guidelines, or they're looking at
CDC.
Yeah. So they know that things rapidly change. So it's easier to say, follow what's on this website than it is to put it in writing. Yeah. Here's some information about the requirements of participation. As I said, a lot of this stuff they reference. For updates, you can look at the PA Bulletin. I highly, highly recommend, if you're not already subscribed, to get the information from the PA Bulletin. It will update you on several changes throughout, whether it's Department of Health, Department of Human Services, Environmental Services. They will tell you what all of their updates are. The IRRC, that is the Regulatory Review Board. So when there are proposed changes, it goes to the IRRC before it can be approved. And then the Pennsylvania Department of Health Message Board, if you go on to there and just look at the message board itself, they will post any updates on that. And here is our information. Also on our website, we do have helpful link section. So you can always go through our website and we can forward you to the message board and of the such.
Thank you so much. This was some great information that you were able to share with our group today. As a reminder, if anyone has any questions, I don't see any currently, please submit them utilizing the Q&A icon at the bottom of your screen. I'll give everyone a moment or two to see if any additional questions come through.
It is a lot of information. They really did a major overhaul of all of this, and we tried to make it as simple as possible, so I hope it wasn't too confusing. But like I said, there are a lot of changes coming down the pike. Some of it may be easy enough because we already follow the requirements of participation, but some of it is a little more in depth and goes above and beyond. So.
And then Kelly asked if she was able to get a copy of the PowerPoint. I will send that along. If anyone does have any additional questions after today's session, please feel free to email myself, Linda, or Jennifer. All right. Well, thank you so much, everyone. I hope you have a great rest of your day.
Thank you.
Thank you.